Outshot inventor is here with us today, and we'll talk about regarding the injection of PRP in order to improve the functionality and the quality of life of our patients. So welcome.
Thank you for your attention. We're honored to be here. We're presenting this data for the first time. It's not been published. And after peer review, there may be more or less included, but hopefully you'll give us some feedback about what you think about our data, and hopefully it will help you think about your patients and maybe even take better care. I do have some conflicts of interest. We're going to talk about the specific method of injecting PRP of the OSHOT, and I founded a for-profit organization called the Cellular Medicine Association. Some of you in the room are in that organization, and I have two nonprofits that help find further research and education. The numbers come from survey data from 2,304 women who were treated and then followed each for a year. And then they were followed by 295 physicians, some of them in this room, who treated them. Here's a list of those physicians. I would like to acknowledge them. In 2010, using ideas that were already in the sports medicine and wound care literature, I had the idea to inject the penis with PRP, which became known as the P-shot, and soon afterwards started injecting female genitalia and registered the idea as the O-shot with the U.S. Patent and Trademark Office in 2012. In 2004, I hired an entire FDA examiner to just do a chart review, and we published a pilot study of the changes in female FSCSR in a small number of patients treated with our protocol. And the study showed improvements, and as a side effect, we saw improvements in stress incontinence. This recent review article showed, just a few months ago, showed 3,660 papers have come out since then. But no one has published a robust, longitudinal, multi-center study of one specific protocol for the injection of PRP for the treatment of sexual dysfunction. On the contrary, most of the meta-analyses complain that the current studies use a variety of injection methods that make conclusions difficult. Also, since some of the studies, this is a list of papers, some of them review articles and meta-analysis of using saline. And since some of the studies use saline as a placebo, not acknowledging that in the orthopedic, sports medicine, and dermatology literature, hydrodissection with saline is used to treat acne scars, leishmaniasis, granulomas, osteoarthritis of the knee, back pain, nerve and muscle injury. Also, a huge body of literature discusses the treatment of pain with only the strategic insertion of a needle in sports medicine, rheumatology, and acupuncture. So the key, I think, that hopefully you guys will help propagate as you do your research is when you recognize that the treatment of soft tissue with PRP is a two-component treatment. One, a physical component of hydrodissection, which is a type of surgery, as you know, needle insertion, and number two, the additional effects of the PRP. There have been lectures yesterday about using PRP as a hydrodissection. So the needle placement matters, the tissue plane accuracy and the volume injection all matters. PRP does not work like a drug where you can just inject it haphazardly and still demonstrate optimal effects. Hence, the protocol matters. And your colleagues waiting for a double-blind placebo-controlled study before adopting PRP as a treatment option will wait a long time. Remember, there has never been a double-blind placebo-controlled study of birth control pills for pregnancy. Not for any surgery and not for parachutes. So in the real world, in science, it starts, yes, we get to the placebo-controlled studies, but it starts with longitudinal observation. So, because of the difficulty in doing a meaningful placebo-controlled study, in 2014, I set up a quality improvement and program evaluation survey to be participated in within the routine clinical operations of our providers in the CMA. Only limited identifiers, initials, month, year, and birth and the providers' names were present in the source records for matching purposes and were not used in the analysis. Prior to analysis, all directly identifying elements were removed, and the anonymized analytic data set was created using study IDs. Following verification of the de-identified data set, original files containing the limited identifiers were securely destroyed, and analyses were conducted exclusively on the de-identified data, which we will make available after publication, which made an IRB not needed. This is the method. Since we conducted a non-randomized collection of survey data, I want you to see exactly how the data was collected. In July 2013, application for treatment.
I got it.
Applications for treatment for physician training started. It was opened up, and applicants with the required licensure were accepted, either online or hands-on training. Many of you in this group underwent that training. Since then, 5,157 physicians or physician extenders in 57 countries have been trained on our protocol. Those who did online training were required to take an online test to document understanding. Providers signed an agreement to follow our protocol with only minimal variations, and then were listed on a directory for patients to find them. At this time, the providers were invited to enroll patients in our survey. The provider was not offered money. On the same password-protected website where the training videos reside, there's a window to another password-protected server where the physician may enroll a patient in the survey. On the day of the procedure, or time zero, the physician logs into the first server to gain entry into the second server and enters the patient's cell phone number, not their name, and the provider's name. From this point, the provider has no access to any data provided by the patient, and all notices come directly from the second server, not from the physician, who has no further involvement. From July 2016 until September 2020, 9 years and 2 months, 295 physicians from 4 countries entered the cell phone number of 3,125 women who were treated with the O-Sharp procedure. No physician entered more than 45, most entered less than 10. Of those women, 2,304 answered at time zero and for at least one other time point. When the women received a text message that let her know it was regarding the procedure and asked her to contribute her observations to help us for future care of women. No money was offered to the woman. A link in the text message took her to a third server, a HIPAA-compliant, privacy-proven component of SurveyMonkey that requested her first and last initial and birth month and year so she could be followed longitudinally, and the name of the person who did the procedure. No other identifiers were collected. SurveyMonkey then administered Female Sexual Distress Scale Revised and asked open-ended questions about her experiences before and after the procedure. Server number 2 then sent the same text message to each woman at 3 days, 3 weeks, 3 months, 6 months, and 1 year in relation to the day she was injected. This continued for 9 years and 2 months until September of this year in preparation for this lecture. We then downloaded the data from SurveyMonkey into a 4th password-protected server where my son, who's a data analyst, used birth month and year and initials to track each person longitudinally and then anonymize them with a computer-generated ID. Providers were assigned a combination of letters. Then that anonymized data was put into a 5th server where mostly Alex analyzed it. She's the mathematician. Analysis focused on 1,273 participants with a baseline FSCSR of 11 or higher, which indicates clinical meaningful distress. Times were FSCSR totals of 0 to 52, the change from baseline, and responder rate improvements of 8, which is considered to be clinically significant in previous research, and 10 points at 3 days, 3 weeks, 3 months, 6 months, and 1 year, with a mean and 95% confidence intervals were summarized, median-based sensitivity analysis also computed. Previous studies show that the placebo response to interventions in sexual medicine showed an improvement in FSCSR by 4 to 6, and improvement by 8 is considered to be clinically significant. Now, Alex will talk about the numbers that she crunched.
So looking at women who presented with distress, FSDSR of 11 or more, the mean total score dropped from 27 to 19, with benefit shown at 3 days, with continued improvement for 6 months and sustained for a year. The mean dropped from -3 at 3 days to -8 at 6 months and was sustained for a year. Treatment response showed a dose-response relationship with baseline severity. Patients with the highest baseline distress in quartile 4, scores 34 to 52, showed the most significant improvement with -19 points at 1 year, while those with the lowest baseline scores in quartile 1, basically mostly not distress, show minimal change or slight worsening. Looking at those starting with stress, over 50% dropped their distress by a factor of 8, and over 40% dropped by 10. 183 of the, or 14% of the Only 183 or 14% of the 1,273 presenting with distress out of the group also completed the survey study at a year. Completion rate varied with age. Completion rate did not vary with the severity of presentations. Baseline severity did not affect dropout. We saw a mean improvement of 8.3 points with Cohen's D value of 0.79, indicating a medium to large treatment effect. Positive treatment effect. To account for non-random dropout, we applied inverse probability weighting to each time point. At 1 year, the weighted mean improvement was 8.53 points, with a Cohen's D of 0.75. After applying inverse probability weighting to account for dropout, the estimated 1-year improvement was modestly larger, indicating a slightly stronger treatment effect. A small percentage of those starting with a score less than 11 saw distress worsen, some because the spouse could no longer match her increased libido. Other side effects were minimal and short-lived. In this real-world, clinic-based cohort spanning a 9-year, 2-month observational period, the OSHOT protocol was associated with rapid, sustained reductions in sexual distress among participants starting with clinically meaningful baseline distress. These findings are consistent with hypothesized PRP effects and with clinical experience, and they motivate randomized controlled trials to establish efficacy, durability, and safety with systematic adverse event capture. Limitations include the single-arm design's potential for confounding and selection bias, visit-level missingness, and the lack of formal adverse event adjudication in the current data set. Strengths include prospective design, repeated standardized assessments over clinically relevant time points, and transparent reporting, including median-based robustness summaries. Regarding safety, adverse events were captured indirectly via participant free text comments solicited with each survey rather than through a structured safety case report form. Across all time points, the most common tolerability signal was transient procedural discomfort. Occasional minor local effects, such as spotting, bruising, or swelling, were noted without apparent clustering. Reports suggestive of infectious complications were rare. As we know, PRP is often used to treat infection, and neurologic and hypersensitivity symptoms were essentially absent in unsolicited comments. Given the passive nature of capture, these observations likely under-ascertain events and should be interpreted cautiously. Future studies should incorporate systematic adverse event collection with predefined categories and timing windows. Let me give it back to Charles now to one more.
In summary, for women suffering psychological distress secondary to sexual dysfunction and an SDSR total of 11 or more, results from the protocol were demonstrated to be robust. Over 50% dropped their total score by age or more. Over 40% dropped their total score by 10 or more. Onset of improvement was early at 3 days. Improvement was maximal at 6 months and was sustained for a year. Limitations include the single-arm design potential for confounding and selection bias. Strengths include prospective design, repeated standardized assessments over clinically relevant time points. Results might be improved with botulinum toxin. As we discussed last year, when you add in botulinum toxin to the clitoral injection, it improves results, and it can be dramatic even when compared to FDA-approved drugs that are on the market right now. Future work to be done includes randomized longitudinal studies. Saline-only arms should be followed, I think, not as a placebo, but to try to figure out what part is being contributed by the hydrodissection, the botulinum toxin to another arm, and we want to always acknowledge that we do not think this is some magic shot. I think you guys see aesthetic gynecology, and of course all of you always remember that it takes all of those things for women to have proper functioning sexuality. There's a systems analysis. So we don't think we have a magic shot, but we do think that it's a useful tool.